Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being.
Take it away, Dr. Borik.
Radio, sponsored by Gilbert Hospital and Florence Hospital at Anthem. Joe, how are you today?
I'm fantastic. How are you, Dr. Borik?
You know, this is our first show where I'm actually leading it and talking from a remote location. I'm used to being there with you in the studio, but unfortunately I'm not in town, so I wanted to call in. And today we have a really, really interesting show in store. I actually have the opportunity to be here with a surgeon from Pittsburgh. She's one of the top docs. She was voted by the Pittsburgh magazine in 2011 as one of the top docs in general surgery and breast surgery. Dr. Ray Budway is here today, so I'm really excited about that. Joe, I got to tell you, Dr. Budway is actually somebody who has done surgery on my family. Is somebody that I would absolutely recommend to anybody. So I feel honored to have her with me today.
Wow, fantastic.
Budway, thank you.
And welcome,
it's
Dr.
great to
Budway.
be here.
So we're going to talk about breast cancer today. Ray Budway is a surgeon who specializes in breast surgery. And so the show pretty much is going to be geared toward talking about some of the screenings, what breast cancer, what do we look for, some of the treatment modalities, and some of the nutritional things that we need to think about in an attempt to try to decrease our risk of developing cancer and recurrence of cancers. Ray, tell me a little bit about, screenings for breast cancer.
Well, the American Cancer Society guidelines still support, although there was controversy surrounding that, still support mammograms once a year from age 40 until age 80. Screening after age 80 and before age 80 has not been proven. Screening before 40 and after 80 has not really been shown to save lives. You use mammography in those instances as a diagnostic tool if you find something on physical exam as opposed to screening.
Let me ask you, though, in people that have a strong family history, do you recommend mammography earlier than the age of 40?
The American Cancer Society guidelines does support 35 years every other year until the age of 40.
Okay.
So it's supposed to be a balance between early detection of breast cancer, which clearly early detection saves lives, and the exposure that you get from mammography to radiation, which enough exposure over the course of somebody's life can also increase the risk of other cancers other than the cancer that you're screening for. So it's a gentle balance, and these are the American Cancer Society guidelines, and that's what most people follow.
So we have to be careful not to recommend mammography too soon. However, we do recommend self-breast exams.
Right.
And really from the age of, 20 on.
Right.
As a surgeon, tell us a little bit about, what you tell your patients. What do you look for? What is the real, way that a breast exam should be performed? How often do you recommend it be done?
Bottom line is you don't want to do an exam right before your menstrual cycle.
Okay.
The breast is more swollen at that time. It's much harder to examine. So generally, the week during or after your cycle is the timing to do the exam. It should be done once a month, and most people are not skilled at breast exams, so we're not asking you to make a diagnosis. We're asking you just to notice changes in your breast. So you have to become familiar with your breast, what logistically and topography-wise. Once you're familiar with that, you'll be able to notice a change.
So really look in the mirror, look at it, get a sense of what it looks like, what it feels like, and notice changes.
Right.
And that's really when you want patients to, that's fine. We started this whole thing, and I introduced you, but really I would like for you to just tell us a little bit about your training and your background. Apologize for not doing that at the top of the show, but if you can give us that background information.
Well, Dr. Borik and I go way back to Philadelphia.
What people don't know, actually, is that Ray and I are cousins, and so this is really an honor for me to have one of my family members on the show. So it's really cool.
So we basically went through school together in Philadelphia. I went to Hahnemann Medical School, which is now Drexel Medical School, that's a whole financial episode in Pennsylvania health history. But graduated from Hahnemann, went on to do my surgical training in Pittsburgh at the Western Pennsylvania Hospital. Then did a critical care fellowship for a year at the University of Pittsburgh Medical Center. And back then, breast cancer surgery was not a specialty. However, being one of very few women surgeons in the area, women with a diagnosis of breast cancer tended to gravitate towards women's surgery, so it became a specialty by default. There's so much knowledge and so much information that's needed to care for these breast cancer patients that it almost inevitably becomes a specialty if you end up doing a lot of it. Right.
Mm-hmm. So right now, in your practice, do you just exclusively just do breast, or do you do general surgery as well?
I still do general surgery. About 90% of what I do is breast cancer surgery, and then the other 10% is the emergency room kind of calls for gallbladders, appendixes, etc.
Right. That's interesting. Exposure to radiation, just getting back to that, because it's something that we don't really think about. Just regular radiation exposure increases the risk of one getting, cancer.
Skin cancer, for instance.
Exactly.
That's sun's radiation.
Perfect example.
Yeah. Mm-hmm. The radiation works in a way that it can change the ability of the DNA and its ability to repair itself. So exposing your cells' the inability to repair damages that are done from ionizing radiation, which is what antioxidants, etc., are geared at trying to help us with.
Right. I hope I didn't miss anything here, Dr. Borik. Our phones are ringing off the hook here. We have 3 questions already, so anytime,
perfect.
Just let me know.
Let's take some questions, Joe.
We've got Bob calling in from San Diego, California, and he wants to know, are men at risk, and do men get breast cancer?
Men? What is it? I'm sorry, repeat that again, Joe.
Do men get breast cancer? Are men at risk?
That's a great question.
Men are not at high risk for breast cancer, but men do get breast cancer. One of the most publicized types of male breast cancer was Mr. Robert Gourmet, who was an actor, African-American actor, popular in the 70s. He had breast cancer. The men that are at higher risk for breast cancer in general are those that have the breast cancer gene in their family, and their risk is much higher than the male general population. If you look at all the breast cancers that are diagnosed in the United States, it's around 230,000 a year are diagnosed. About 1% of those are male breast cancers.
So do you, in your recommendation, if somebody does have a family history of breast cancer, now would that be on their mother's side or the father's side?
It does not matter.
Okay.
The breast cancer gene is an autosomal dominant, which means that you have a 50% chance of inheriting that gene from either parent. And if you have a strong family history on one side, then there are some subtleties to who we recommend for the genetic testing. But in general, if you qualify, insurance covers the cost of the test, which is somewhere around $3,000.
Wow.
So if you qualify as somebody that's high risk, we run the test, and then the male persons in that family are also at higher risk for breast cancer.
And we do mammography on men. I mean, just like we do on women.
We do, but not for screening. In general, we use that if we feel something or if something's brought to our attention in the male breast. Men can develop breast tissue as well. That's called gynecomastia. So it's a difficult diagnosis to make, whether or not it's just male developing breast tissue or cancer in the breast, and that's where we come into play in helping them make that diagnosis.
Excellent. That was a great question. Joe, do you have any other questions?
Absolutely. Mary Lou from Baton Rouge says, I have nipple discharge going on 2 weeks. It's clear to yellowish. Does this mean I have cancer? I'm a 52-year-old female and have had a hysterectomy at age 42.
I'm sorry, you broke up. Did you get that?
Yeah, a 50-year-old female with nipple discharge?
Yes, clear to yellowish, and she's had it going on 2 weeks, and she's 40. She had a hysterectomy at age 42.
That is clear to, there's differences in nipple discharge in general. They're what we call physiologic discharge, which is something that can naturally happen in all ages of women, versus pathologic discharge, which is something that can indicate underlying abnormal pathology. The categories of discharge we generally recommend to investigate are those that are coming from a single breast and clear or yellow discharge. So this is something that should be investigated. I'm not saying that it is something, but it probably it can be something associated with underlying pathology. So she should have that investigated.
That's fantastic. Let's move along to Ren from Toledo, Ohio. I take hormone therapy since menopause. Does this increase my risk?
It does increase her risk for breast cancer.
That's a great question. Maybe we can talk a little bit about hormone replacement therapy.
The recommendation in the 70s and 80s and even early 90s was to use hormone replacement in those women that have gone through menopause because their estrogen levels were decreased. The reason we used it was that it would decrease risk of future risks in those women of bone health and bone fractures, as well as cardiac events. When we were using it, we also noticed an increase in the risk of breast cancer. So hormone replacement therapy can be indicated in certain patients that are at very high risk for fractures, but there's other ways to handle that risk that are less risky than hormone replacement.
I don't know, today it's just fallen out of vogue. Just with the increased risk of cardiovascular events and strokes and those kinds of things, it's really not something that we recommend.
Right.
Especially if there's a remote history of breast cancer, it's something that absolutely would recommend not taking.
Correct.
Yeah, that's a very good question. Joe, do you have any other questions there?
We do. Beth from Worcester, Massachusetts, a 35-year-old breast cancer survivor, now pregnant, and wants to know, is it safe to breastfeed?
That's a great question.
Obviously, she has breasts to utilize, so she had breast conservation surgery, and Ann and I had planned to talk about the surgical options for breast cancer. But, yes, it is safe to lactate and to feed. It's not as successful as somebody that has not had treatment in their breast. The radiation potentially that was part of her treatment might inhibit her ability to breastfeed from that breast. But the other breast should be fine to breastfeed from. So it's not a contraindication. In other words, we don't not recommend it, but she might not be as successful at being able to feed.
Right. Let me ask you a question. Is there a higher incidence of mastitis or anything like that?
In the treated side,
In
yes.
the treated side, yeah.
Yes.
It would be interesting to know if she had radiation therapy, on that side or not. But that's a great question. Very good. Any other questions, Joe?
We've got one more, and then I'll go ahead and turn the phone lines back on, and I'll field some more calls here. Cindy from Westlake Village, California. I have very large natural breasts, and am I at higher risk? I do get bruised a lot on the breasts.
Bruises, is that right? Like trauma?
That's pretty much all she said there.
I didn't quite. Can you repeat the question?
Oh, sure. I'm sorry. I have very large natural breasts. Am I at higher risk to begin with? Second of all, I get a lot of bruises on my breasts.
Okay. Good question.
The risk of future cancers doesn't depend on the size of the breast, but rather the density of the breast. So it's almost impossible to answer her question. But in general, highly densely breasts have a slightly higher risk of breast cancer than the general population.
Mm-hmm. Right. But just because somebody has, larger breasts absolutely does not put them at a higher risk.
Correct.
Is that what you're saying? Okay.
Yes.
Okay. She mentioned bruising. Let's just talk about trauma. The Olympics are about to start and, full contact sports and, trauma and all of that. In your opinion, is trauma to the breast, does that increase one's risk for breast cancer?
Supposedly not. Now, every person that treats breast cancer has had patients that come in with a story that, they had trauma in that breast and now they've developed the cancer in the same area. Mm-hmm. We've not really shown a definitive correlation with trauma and breast cancer, but we all have those stories.
Right, right. I mean, I for one, had a bruise, and so we're always looking to make sure that we protect the body and do that the best we can.
One thing is for sure, if you develop a mass, which sometimes a bruise can be, then that will need to be investigated.
Right. Good. Joe, any other questions there?
You know what? I got one more that just snuck in here. Tammy from Las Vegas, Nevada. Could you please tell me the warning signs to look for? My mother is a breast cancer survivor.
That's a good question. Just some of the warning signs, if we can just talk about. Her mom is a breast cancer survivor. And Tammy, I wonder did she say how old she was, Joe?
No, she did not. I'm sorry.
Okay. We can just in general talk about some of the warning signs and what to do.
Well, I've always participated in the screening program because we do know that screening saves lives in breast cancer. That includes mammography and self-breast exam, and a yearly physical exam by your primary care doctor, your gynecologist, or a breast surgeon, or somebody in the breast field. So those three things are necessary, as well as nipple discharge, skin changes, any of the things that you would associate that you can see even on the internet nowadays. Any of those things would be something that you're looking for.
Right. Just some things we're going to be talking about here in a bit is nutrition. The importance of nutrition for breast health. Just one thing that I really want to make sure that gets heard out there is that fruits and vegetables, low-fat diet, we'll talk about that in a bit, is really, the cornerstone of helping to prevent cancers. The studies show that, and so that's very, very important. Try to exercise on a regular basis has also been found. So those are the things that we would recommend. Anything else? I think that's pretty much everything.
Yeah.
Okay. Joe, any other questions there?
Just got another one in. Cynthia from Queen Creek, Arizona. I get regular benign breast lumps. Have had 2 lumpectomies. Do I expect one of these times I will go into my physician and have cancer? I suffer from depression over it.
She suffers from depression. Is that what you said?
Okay, let me start again here. I get regular benign lumps on my breasts. Have had 2 lumpectomies. Did you get that?
Yep.
Do I expect one of these days I am going to walk into my clinic with a lump and I will have cancer? I suffer with depression because of it.
Okay, right. Did you hear that?
Mm-hmm.
Okay. Let's just talk a bit about benign, masses and so forth, and lumpectomies, and if you could just in general.
Everything that you see as a change or feel as a change in your breast should be investigated. Because even though you've had a history of benign lumps, that doesn't mean that the next lump is not a cancer. And of course, that all depends on age and risk, etc. The age categories that are at highest risk for breast cancer are still in the 50s, women in their 50s. Women in their 40s aren't in the highest category, and women in the 60s aren't in the highest categories. In other words, the incidence are highest in the 50s. So each lump will need to be investigated, unfortunately, and that can lead to anxiety surrounding that. But just because you're anxious and just because you've had a history of benign lumps doesn't mean that the next lump shouldn't be investigated.
Okay. So what you're saying is that just because somebody has a history of benign fibrocystic breast disease, every time something pops up, definitely should be investigated.
Correct.
Right. And I think that's probably, a correct. What about caffeine? This is just something. Do you, in your experience, do you find that caffeine increases the incidence of
breast
breast tenderness and fibrocystic tenderness and that kind of stuff.
That actually has been disproven in randomized controlled studies, but it's still a misnomer out there. Caffeine doesn't really participate in breast pain. Most breast pain is, in fact, 99% of breast pain is benign. There is about a very small percentage of cancers that will present with pain, but most pain in the breast are of benign etiology. Most pain is also cyclic, so there's cyclic pain from your cycles, which is generally the week before your period, and also cyclic pain that is not associated with your cycles. And what that means is that women will have sometimes excruciating pain in their breasts for 3 months at a time. It'll go away for a few months, and then it'll come back. And we have no explanation for that pain, so we can't really treat it very well, unfortunately. There are several European studies showing that the months-long cyclic pain can be treated with anti-estrogen drugs in a safe manner, but everything that you take has risks and benefits, so it really becomes weighing those risks of that medication versus the pain that you're having and how that should be appropriately treated.
Right. So breast cancer really is not painful. Usually it presents as a benign, as a painless, mass or whatever it is. Yeah.
Most breast cancer today actually is diagnosed by screening. So women don't feel it.
What about, one breast is larger than the other? People that, have one breast that's bigger than the other, is there any incidence? That's an anatomical thing that oftentimes they're born with. Can you speak to that? Is that playing into any diagnostic, thoughts at all?
I've been treating breast cancer for 25 years. Nobody has the same size breast. Everybody has one breast slightly larger than the other. The degree obviously changes from woman to woman, but nobody's breasts are perfectly symmetric.
Okay, and that's important to know because, women out there that are, doing breast exam and they find that one is a different size, they get, anxious, and so that's very normal.
That is very normal, yes.
One more thing, just in terms of, breast exams and so forth, under the arm, the axillary area, that is part of, the breast tissue can extend up into that area and even along the side as well. Do you tell your patients anything in reference to extending the exam area, beyond just the breast?
No, actually, women are pretty much in tune, women and men are in tune to their body, so their exam generally will cover their own breast tissue because inherently your body, where your breast tissue begins and ends. So most people cover that anyway. You don't need to go over that. But if you have a question of, hey, is this breast tissue or should I be feeling this, of course, bring it up with your physician.
Right. I think that's important because as a primary care doc, sometimes I see that, and that's been a question. Joe, any other questions or comments out there?
Sure. We've got Rhonda from St. Louis. Are you hearing me okay? Dr. Borik, do you hear me okay?
Yeah, we can hear you.
Okay, great. Rhonda from St. Louis is considering implants. This is kind of a two-part question here. Can you recommend a type of implant, have had a mastectomy, and is having a hard time dealing with the social issues of missing a breast? If I do get the surgery and get implants, what do I do for the nipples?
Okay, that's a good question. Did you get that right?
No, because Joe was coming in and out. The first part was, do we recommend implants?
And what kind of implant, right?
That's really a question you want to approach with your plastic surgeon that's doing the augmentation or reconstruction, depending on whether or not the breast is removed or not.
I think what you wanted to know was what type. Being that there's different types,
there's
and I'm not sure what they are, but
and there's different types of implants.
I'm the person that removes the tissue, not replaces it. But in general, those risks and pluses and minuses, the pros and cons for each type of implant should be addressed by your plastic surgeon that you're speaking with when you're considering these types of operations.
Right. So, as a general breast surgeon, you basically, when you do a mastectomy, for example, do you oftentimes have a plastic surgeon right with you to, kind of give us a little outline of how that whole thing runs? If you're, doing a mastectomy, how does that look?
We'll walk through from the start.
Perfect.
Most breast cancers, as I had mentioned earlier, are diagnosed mammographically or by screening methods. So these are small, what we call early-stage breast cancer. When you look at early-stage breast cancer, generally surgery is the first step in their care. So we, as the surgeons, become their intimate partner in helping the patient negotiate the waters of their treatment. Since surgery is the first step, what I'll do is bring a patient in, we examine them, we go back in our conference room and we talk about their treatment options. Treatment options for breast cancer today for early stage still include the old-fashioned mastectomy. It's an operation that's been around for 100 years. First reported mastectomy to show success in treatment for breast cancer was in 1904.
Wow.
Yeah.
Wow.
So it's still an option, and it's a necessary option for patients that have multiple tumors in their breasts, or tumors that are too large for the size of the breast to save the breast and have something that looks relatively normal. So if you have a large breast with a small breast with a large tumor, you're not going to be able to offer that woman breast conservation because you're going to give them something that's very disfiguring. So mastectomy is still an option today. The second option from a surgical standpoint is what an operation commonly known as a lumpectomy. Most of us refer it in the profession as a partial mastectomy because we're removing part of the breast. Whenever you remove part of the breast, there's breast tissue left behind that still has that tendency to make the change towards cancer. So the rest of the breast tissue that we've left behind needs some type of treatment, and that treatment to change the milieu is radiation. So partial mastectomy plus radiation is equal to a mastectomy in what we call surgical treatment options for breast cancer. If you take 1,000 women and you randomize them between mastectomy versus partial mastectomy plus radiation, the same number of people are alive in each group, indicating they're absolutely equal treatments for breast cancer. You do not need a larger surgery. You don't want to think of this as a larger surgery has a bigger chance of curing you of your cancer. That's not true at all. The lesser surgery has just as much of a chance of curing you.
That's a great point. Mm-hmm.
So we walk the patients through understanding the surgical treatment options, and the other part of the surgical treatment options are things that we do to help the patient and the oncologist prepare for the next step of their treatment, which is adjuvant treatment. So in order to do that, we have to try to guesstimate the aggressiveness of that cancer. And how we do that nowadays is a couple of ways. One is we still look at the lymph nodes underneath the arm. So we biopsy the lymph nodes underneath the arm with something called a sentinel lymph node procedure. What that is figuring out which lymph nodes are draining the tumorous area of the breast, identifying them at the time of surgery with a couple of techniques, and removing those lymph nodes to see if those are involved with cancer. Then we can stage the patient appropriately, understanding whether or not the lymph nodes are involved. The other thing that we do is in half of the patients that have breast cancer, those half of the patients that have estrogen-positive breast cancers, we remove a portion of their tumor and send it off for an analysis of different proteins. And depending on which proteins are expressed or not expressed, we come up with a recurrence score. And that helps the oncologist and the patient understand whether or not they need any additional treatments, and additional meaning additional to surgery, those being chemotherapy or anti-estrogen drugs.
Very good. So just just to kind of clarify, there are some cancers that are receptor positive to estrogen and progesterone, and some that are not.
Mm-hmm.
And it's just a matter of finding that out and then doing all of the other testing and to see what the best adjuvant chemotherapy would be.
Right.
Okay. Joe, any other questions out there?
Oh, they're coming in.
This is, Joe, I think this is probably our all-time high call-in number.
I would say so. Tina from Orlando says, I'm embarrassed asking, but I really want to know. My partner does a lot with my breasts daily. Does this put me at higher risk, and is there something I can do to keep my breasts healthy?
Okay, so intimately, I guess this person saying that their partner does a lot of things with their breasts, does that put them at a higher risk? Is that the question?
That is correct. And she also said sometimes that she will have nipple soreness for 2 to 3 days. That's all she said.
That's a good question.
In addition.
Right. You want to answer that?
Well, I can say that nipple soreness is probably normal. Whether or not it puts you at higher risk, I honestly have no idea.
Mm-hmm.
I just have not been posed with that question, nor have I ever looked it up. So.
But from a research standpoint, I don't think that there's any literature.
I can't think of anything that makes jumps into my head.
Right.
From the idea of jumping from idea to idea.
From a sexual standpoint. Okay, that's a great question, though. Any other questions, Joe?
Marge from Los Angeles wants to know, is it safe to get breast reduction surgery?
Great question.
Yeah, breast reduction surgery is very safe. It's a necessary patient in those patients with really large breasts that it affects their posture and their back. Large breasts can really lead to chronic back problems. So it's a necessary procedure in certain patients. We like to screen those patients very thoroughly before they undergo breast reduction because if the tissue that's removed during the reduction does contain something that needs further treatment, it's nice to know about that beforehand because oftentimes procedures can be combined with the reduction with treatment, surgical treatment options, as well as just even other things like high-risk patients, et cetera. We can do certain things to make those patients have lower risk in the long run.
Mm-hmm. Very good. Anything else, Joe? Any other questions?
Nancy Durad from Nebraska. Are underwire bras harmful to wear?
Say that again. I'm sorry.
Are underwire bras harmful for me to wear?
Very good. Are they harmful to wear? Mm-hmm.
No. That would probably go along with the trauma question, an underwire bra being constantly traumatic to the inferior surface of the breast. We haven't proven that has been, with definitive information, that's a high risk.
Right. And by the way, the person that called and asked about the trauma to the breast, the fact that a surgeon really has never needed to answer that question, that's good news. Because, just to kind of put your mind at ease, I think that, the type of bra that you wear, trauma, that really doesn't increase the incidence of breast cancer from what I'm hearing.
Right.
And that's good news. Yeah, that's good. Any other questions, Joe?
Yes, Peggy from Phoenix. Sometimes my breasts feel lumpy and other times not. How do I self-exam? I have generations of cancers in my family.
Okay. So family history,
definitely Peggy's at high risk, and she would be one of those people that are difficult to follow because she has lumpy, bumpy breasts. Screening is very important, and this is an avenue where we would consider using an MRI as an additional screening tool in a patient like Peggy.
Let's talk about MRI for a minute. It's a pretty new modality.
Yeah, MRI is a great tool. My background is in chemistry. It's magnetic resonant imaging. So we're flipping chemical protons in the body and generating an image with this. So it's an amazing tool. And there'll be more and more identification in the not so distant future where we're injecting certain molecules, and we'll find these molecules on the MRI highlighting cancer cells. That's not in the very near future, but the not-so-distant future.
So when do you recommend an MRI? I mean, if somebody, we don't want to consistently expose people to the radiation. Is MRI a tool that is now recommended as a routine screening for high-risk people, or?
Those that carry the definition of high risk, so those that have an extreme family history, those that have been diagnosed on a biopsy with funny-looking cells or atypical cells, atypical ductal hyperplasia, atypical lobular hyperplasia, or those with LCIS. So all of those patients are definitively covered with an MRI. An MRI is a great tool at identifying cancers, and we're even becoming better at identifying precancerous lesions by MRI criteria. So there are certain aspects to understanding the information in front of you, and you should go to a designated center that has the ability to do this and is read by a qualified breast imager.
Right. And there's no risk in terms of the radiation exposure.
No, there's not risk from radiation. It's magnetic energy, so there's no radiation risk. There is risk because there is a contrast agent that's utilized, and some patients do have an allergy even to this lesser contrast.
Perfect. Okay. Very good. Joe, any other questions out there?
48-year-old Annie from Bullhead City says, I have fibrocystic breast disease. Does it lead, or can I expect cancer in the future?
No, fibrocystic disease is a completely benign disorder. The only problem it causes is those patients generally have, again, lumpy, bumpy, dense breasts. So those are the people that it's harder to identify something if it does develop, if cancer does develop in those breasts. It's a little bit harder to identify. But it doesn't put you at any higher risk than the general population.
And is there anything that these people can do? Is vitamin E recommended? Or, we talked about caffeine. Is there anything else that you can think of that is recommended?
There's nothing that has definitive data associated with it to decrease the lumpy bumpiness.
Okay, good. Good question. Joe, any other questions there?
Sarah from Savannah says, thank you so much for this show. I feel relieved after listening. And right now I'm caught up, so I'm going to take a couple of minutes here and just field some more calls and write them down, and I'll be back with you.
Great. Good. Ray, let's talk a little bit about nutrition for the breast and, breast health.
Once somebody's diagnosed with breast cancer, we have shown with definitive data that a low-fat diet decreases the chances of not only the chances of the current cancer that we're treating from coming back, but also the future risks of additional breast cancers. So when somebody's diagnosed with a breast cancer, they have a slightly higher risk than the general population of a second breast cancer. So we recommend a low-fat diet. That is the definitive medical information that we have. Other things that you mentioned, vitamin E, any of the other nutritional things supplemental things that you can think of.
Vitamin C and those kinds of things.
We haven't had any definitive proof of whether or not they help or hurt.
Okay. I want to just talk a little bit about the Mediterranean diet. Because there's a lot of research showing that the Mediterranean diet is exactly what you're saying. It's a low-fat, high in fresh fruits, fresh vegetables, vitamin C, those kinds of things, antioxidants. And I think that's really important. There was a couple of studies that I just want to bring out. Just before the show, we were talking about different recipes and different foods. And
because these are near and dear to our heart.
They really are. Actually, Ray is a great cook and cooks mostly Mediterranean food, right?
Yeah.
But there's something, I'm just going to talk a little bit about some of the foods in the Mediterranean diet. And, you can kind of chime in. But there's something, Joe, that's called tabbouleh. And it's predominantly parsley and bulgur wheat, mint, tomato, onions, and lemon. And, for the listeners out there, I'm just going to give you a little thumbnail sketch of what tabbouleh is. The parsley that's found in tabbouleh is probably one of the world's most popular herbs. And it provides there's two particular things that it provides. One is that it has a flavonoid, which is an antioxidant effect that really helps to prevent the oxygen-damaged cells, damage to the cells that Dr. Budway was talking about earlier.
which is where radiation can injure cells.
Exactly. So parsley, in effect, can help to prevent that, to a certain extent. It's an excellent source of vitamin C, vitamin A, folic acid, iron, and it also has something called volatile oil. And I don't know if you know what this is, but I really didn't until I looked it up. But it really is it's in the food that helps to neutralize carcinogens. The benzopyrenes that are part of cigarette smoke exposure and charcoal. When you highly charcoal grill foods and to the point where they're very well cooked, there's carcinogens in that. And there's something found in parsley that helps to neutralize that. Kind of interesting. So just to put it out there for the listeners that are listening, to think about eating not necessarily to, lose weight or gain weight, but more for health. Food as a prescription for the body, I think, is very, very important. Just the other thing I wanted to say about parsley is that there's something called apiginin, A-P-I-G-E-N-I-N, and it's been found to have some anti-cancer activity. And what it does is that it affects and decreases neovascularization, new blood vessels from feeding a tumor. And I think that's a pretty important, point. These are just a little bit of so much out there in reference to the research that is done looking at the Mediterranean diet. So I just wanted to kind of throw that out there. I don't know, hummus that we make. People know about garbanzo beans. I just wanted to make one more comment about that. The chickpeas, along with garlic and olive oil and lemon juice, all of that is just really healthy eating. It has manganese, which is an antioxidant, and it helps to, help energy in the cells of the body. So these are just some of the things that we recommend.
I would just like to comment about the nutritional value of garlic. Mm-hmm. It's a flavor. It helps. It's an anti-cancer agent, but too much can be bad. It can cause problems with your kidneys, and specifically from a surgical standpoint, it can cause bleeding at the time of surgery.
That's interesting.
So some of the things that you have to be aware of when you're using nutritional supplements, number one is moderation is the key. So getting these supplements through eating healthily is probably more important than taking them as a supplement.
That's a great point.
So garlic in hummus is great, but garlic pills and extra garlic is probably not.
Mm-hmm. Speaking of, as a surgeon, what other things would you recommend that people avoid, if they're coming in for surgery to prevent bleeding?
One of my worst nightmares is a patient on fish oil. We're taking fish oil for heart health. Mm-hmm. So I would say a good percentage of my patients are on this, mm-hmm. And it can cause it inhibits the ability for the patient to form clot. So particularly patients that are having a mastectomy, where you're doing a lot of dissection, this can cause a lot of bleeding at the time, not at the time of surgery, but 6 hours, 8 hours later. So fish oil is something that we recommend avoiding. Clearly aspirin. Everybody knows about the mm-hmm. anti-platelet effects of aspirin. This is something you want to avoid prior to surgery, mm-hmm.
And
some of the other anti-platelet agents.
What about anti-inflammatories? Do you recommend holding those, 7 days or so before surgery?
Yeah, aspirin 7 days, mm-hmm. Motrin, ibuprofen, all of the other anti-inflammatories are 2 days.
Or 2 days, okay. What about vitamin E? If you know somebody's on it, how long do you tell them to hold it for?
2 weeks at least.
Really?
Vitamin E is a fat type.
It's a fat-soluble vitamin. Right.
So you want to hold those for at least 2 weeks.
So A, D, E, and K, if anybody's on high doses of that, that should certainly be held mm-hmm. from a surgical standpoint.
Right.
Hopefully I can jump in here with this one, and I apologize. This came in later than some of the other questions, but this applies, and I'll get right back to the other ones here. How much ahead of surgery should you stop fish oils, etc.?
A minimum of 2 weeks. A month is nicer. It's not an emergency. Unlike aspirin in some patients that are at high risk for stroke or etc. Fish oils, you're not going to have, by stopping it, you're not going to have an emergency coronary event. So this is something that if you can plan for it, try to stop it at least a month. At least 2 weeks, but hopefully a month.
And as a hospitalist, one thing I want to say to the listeners out there is that if it's important to give all of the medications that you're on. A lot of times people bring the list of medicines that they're prescribed, but they don't talk about the over-the-counter meds. And this is a perfect time, an example, from a surgeon telling us, how important it is to know and to stop, a medication that is non-prescription, because it can be pretty lethal and dangerous. So it's important to have a complete list of all of your medications for us when you come into the hospital or to the doc's office.
Oh, yeah.
Yeah, that's key. Joe, any other questions there?
Oh, absolutely. What are your thoughts on the BRCA gene test? Do you think female family members should be tested if an immediate family member has had breast cancer?
The red flags, so to speak, are somebody with a diagnosis of breast cancer in the family before the age of 40, so an immediate relative before the age of 40, more than 2 family members, immediate family members in the same family with breast cancer or ovarian cancer, and multiple generations of breast cancer in the same family. So grandmother, mother, daughter, cousin, etc. So multiple generations, more than 2 or more family members, and then the diagnosis of cancer prior to the age of 40 are all red flags that family should be tested. There are certain ethnical considerations. Ashkenazi Jewish population has a very high preponderance of the BRCA gene. So if there is high risk in the family from the standpoint of multiple family members, but you're not really sure, it's always good to raise the question with the healthcare provider, and then they can help determine whether or not testing is warranted. There are pros and cons to. You just don't want to have this test done willy-nilly. And I'll give you a family history that kind of helps you understand why I said that. I had a woman that was determined high risk. She wanted to follow with me, so we followed her with MRIs and mammography for a multitude of years. She was eventually then diagnosed with breast cancer. She had a sister that had been diagnosed with breast cancer at the age of 32. So we then went on and did BRCA testing on her. She tested positive for the BRCA2 gene, and we knew the explicit location in her gene for this abnormality. So the rest of her family members were then tested for that explicit abnormality. Her older sister was then diagnosed about 5 years later with breast cancer. And we said, hey, this can't happen. You didn't have the gene. Well, believe it or not, she had a BRCA mutation, a BRCA1 mutation, and we think that hers was a spontaneous mutation. So what I meant by willy-nilly testing is that all that type of testing is very complex, and it should be followed very carefully with a healthcare provider. That healthcare provider is not just generally a surgeon, it's also a genetic counselor, because you want to understand the implications of these tests once they do test positive or test negative. All of those things are very much helpful to the patient in being explained by the healthcare provider.
Right. Good question. Anything else, John?
Yes, and I just want to say I want to thank all the callers. It's been absolutely amazing, all the callers and the chat. And I just want to apologize because we're definitely not going to get to all of the questions today, but I'm doing my best here for you. Let's see. Dr. Ray, could you tell us about the advancement of technology since you began doing surgery, and do you utilize robots or robotics, etc.?
Robotics. Interesting.
Not for breast surgery. I do use robotic surgery. Mainly, robotic surgery has been very much taken advantage of in the gynecologic world as well as the urologic world. So prostate cancer, it's one of the main tools used in prostate cancer management now, as well as uterine cancer, ovarian cancer. It's not so much taken advantage of in the general surgery world, other than colon cancer. Robotic surgery is utilized very heavily in colon cancer and rectal cancer. From a breast cancer standpoint, we really don't have a way to apply the robot yet, but believe me, I'm thinking about it, because this is fascinating technology, and I really like using the robot as a tool in the abdomen.
I know there's a couple other questions, but incidence of infection, is it been found to be any lower with the robot, or is there any study showing that, or no?
The main advantage on the robot is ergonomics for the surgeon.
For the surgeon, not being able to get their hand in where it should get through. The body posture of the surgeon. Laparoscopic surgery is very tolling on the performer. The colon surgery takes about 2 or 3 hours. You're in a position hunched over a patient with your arm extended for a good amount of time. So your neck and back and shoulders can really ache after a relatively long laparoscopic procedure. The robot erases that from the surgical standpoint. What it adds on the patient care from the patient standpoint are basically 2 things. The visualization for the surgeon is incredible because we have stereoscopic vision with the robot. And the other is pain management. The robot, believe it or not, is gentler than a person. Wow.
We can, as a person, we can torque our instruments through the abdominal wall to apply the maneuver that we want inside the abdomen because we have a sense of feel of what that instrument needs to do. The robot doesn't have that, so it's relying on coordinates and only moves in a controlled fashion. But of course, the robot is being controlled by the surgeon, so the robot's only as good as the surgeon at the console. But in general, the pain control for robotic surgery is a lot better than laparoscopic surgery.
In infection, there's really no
difference.
No difference. Interesting. Okay, good. Joe, what else you have out there?
Let's see here. Should a female younger than 40 have annual mammograms if an immediate family member has had breast cancer?
It depends on the age of that immediate family member. If the immediate family member was postmenopausal, that 35-year-old or 30-year-old is only slightly higher risk. Whereas if it was premenopausal breast cancer, then that 35-year-old should have mammograms, but it shouldn't be every year. It should be every other year, which I never really understood starting at 35. Why not start at 34 every other year? Somebody can't do math there. But in any event, they should have every other year mammograms. The reason we don't recommend every year in a 35-year-old is that most of the time when women in their 30s have very dense breasts, and mammograms become less sensitive at picking up abnormalities. So a mammogram isn't the best tool for early or younger patients, but it is a good tool for certain things. It's a very good tool for calcifications. Great example is one of my favorite patients that I've ever treated. Was 35 years old, thought she should have a mammogram, asked her gynecologist for the prescription, went and had her mammogram at the age of 35, and she had no indication to have a mammogram at that age.
Wow.
Her first mammogram showed an extreme amount of calcifications in the upper outer quadrant of one of her breasts, and this woman had a precancerous lesion. So had she not asked for that mammogram, and had her normal screening mammogram at the age of 40, she would have already had a cancer at the age of 40.
Right. Wow.
And so there are some people where mammogram is a very good tool. So we can never predict that until we look at the film. So the 35-year-old with a high risk should have her mammogram be evaluated whether or not it's a good tool for her screening, and then go on from there.
That's interesting. Wow. So any other questions there?
Yes. Let's see. We have Marcia from Vancouver. Marcia from Vancouver.
One or two more. We just have a few more minutes to go, and then we'll be closing our show out.
All right, let's go to Marcia from Vancouver. I have really small breasts. I'm 49 years old. They are too small for mammograms. I have never talked to a physician about alternatives because I've been too embarrassed. What can I do to have my breasts examined?
Well, that's a good question. Really, physical exam and ultrasound are probably your other two modalities that would be helpful in that scenario. The embarrassment issue, really, you should never be embarrassed about your own body image. However, you need to be aware that you also have to have screening. So you should be able to discuss this with your healthcare provider on the best screening for you specifically. But a physical exam and ultrasound sound like they might be good tools for you.
Absolutely. And, and as you said, talk to your primary care doc. There's some other modalities out there, and but one thing, don't ignore it. I think that's probably the biggest message that we can we can put out there. Yeah. Joe, maybe we'll take one more question.
Okay, we'll go with Anna from Park City, Utah. I noticed my nipples starting to change color at the age of 40. I'm now 44, and they're completely different colored. Now they're brown. They've been darkening. Should I be concerned?
Good question. Mm-hmm.
Actually, that's a normal physiologic response to pregnancy. Anybody that has had a pregnancy, their nipples have a darker pigmentation to that, and it might be just related to having had a pregnancy.
Right. And what if they were not pregnant? I mean, is it just a physiologic?
It can
change?
be, yes.
Mm-hmm. Okay. Okay. Good.
Nipple lesions to worry about are scaly rashes. Can be indicators that there are a precancerous lesion in the nipple itself. So pigmentation in general is not a concern, but rashes or scaliness or an irritated nipple is something that sometimes needs to be investigated.
Yeah. Sometimes I see, athletes who run a lot, marathon runners and so forth, that, that have a lot of irritation and rubbing. If you have a reason for it, sometimes that's okay, but, certainly don't ignore it.
Right.
And again, have it looked at, and usually for the most part, it's benign, it's nothing to worry about, but obviously it's something that needs to be looked at. Good. Joe, I guess I can't believe this hour is up. This has been a really, really great show. Joe, anything else that you want to ask us before we close over here?
Maybe some contact information or a place to send for further questions. And again, I apologize if we didn't get to everyone, but we do this every single week, different topics. Please continue to tune in and enjoy DocTalk Radio with Dr. Ann Borik. It's been a wonderful show. And thank you, Dr. Ray.
Oh, sure. It's a lot of fun.
It's great. We have a website, and for those of you out there, if you're not on our Facebook page, come on board, and we'd be happy to answer whatever questions we can, on the Facebook. And that's it, Ray. Thank you so much for being here. Great, that's great, Joe. Thank you. We'll see you next week.
Thank you, Dr. Borik.
Bye bye.
This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.